after surgery. But though it has advanced, but even then the posterior capsule rupture is still the most dreadful complication which can affect the visual acuity. So understanding the consequences of PCR on refractive outcome and what management strategies can be done at the time of surgery is very important. So,
Excuse me, can you close the door please over there?
so by evaluating the type of IL used and the adjustment made intraoperative surgery, it provides an insight into optimal management strategies for PCR. So my aim is to evaluate the post-operative refractive and visual outcome in patients with PCR. To study the so the key objectives are impact of PCR, effect of PCR on post-operative astigmatism, the IOL adjustment, and to document and analyze post-operative complication associated with PCR. So it is a retrospective study conducted at tertiary care center. Single surgeon has, these are the case of a single surgeon operated cases. For the duration was 4 years. Inclusion criteria were all the cataract patients. These are the SICS patients. On the patients which we have done SICS and they had PCR. So we have included such patient and who has a follow-up of 6 months at least, minimum follow-up. We have excluded all the other patients. So data was collected from electronic medical records. So preoperative examination, surgical notes, IOL implanted, postoperative refractive correction, IOL calculation adjustment, all these were recorded. So in case of PCR, the lens were placed in the sulcus or scleral fixation and iris claw fixation. If there was a vitreous was there, the anterior vitrectomy was performed, manual vitrectomy with the help of intercameral triamcinolone. So IOL was sulcus IOL, iris claw and scleral fixated. We have followed the patient for 1 day at first day, 1 week, 1 month, 3 months, 6 months, and 8 months and 12 months. So at the time of PCR, I have implanted the lens in the sulcus. So mostly have used a suture aided in case of a larger PCR rent. So that so if the lens, so that there is not a lens is not either placed in sulcus, one is in sulcus or one is in the bag. So that there is an effective placement of the lens in sulcus. And iris claw also with the help of a suture loop I have placed. The advantage is that when we enclave the one claw, at the time of putting the other claw, it can sometimes display, so there can be a phakic or a phakic zone. So to eliminate this, so to aid, actually to help this, I have put a suture loop. Descriptive statistics were used to analyze the data, mainly mean, standard deviations, and frequency. The study was of 65 eyes. So 35 eyes we have applied retropupillary fixated iris claw lens, 29 eyes with PCR and sulcus, and 1 scleral fixated lens. The mean postoperative visual acuity was 612. So the observation time was around 8 to 10 months. The ocular pathologies in which we have applied iris claw and sulcus were like 24 eyes had pseudoexfoliation syndrome. The other were the second most common was rigid non-dilating pupil. The most common post-operative complication which was there in my study was post-operative hyphema. There was very less IOL subluxation or decentration. The mean post-operative refraction was minus 0.5. This is spherical equivalent in 19 eyes. Next is minus 0.75 to minus 1. So though there is a PCR, but a little bit of the lens correction was like in sulcus, we have deducted minus 1 diopter from the actual lens in intraoperative, and in case of sulcus, in case of iris fixation, minus 1.5 diopter was deducted. So the mean postoperative visual acuity was 612 to 69. The hyphema which was observed were basically because of the iris handling during the iris claw. Because while using the Simsky hook from the mostly when the tucking was done from the left hand, it was a force was more which was causing the hyphema. So a more blunt instrument like iris repositor can help it more to reduce the hyphema. IOL decentration and subluxation were rare in my study and they were managed later on. Thank you.
So what's your conclusion.
Sir, my conclusion is that PCR are gonna be there in whether, however, we are like a senior surgeon or eventually, but PCR there. But only thing what you have to do is the intraoperatively, how can we manage that thing? How can we place the lens at that point? What correction we can put the lens? Like how much reduction should be there? How much lens
And-
less tilt or
And
decentration?
manual vitrectomy was
Sir, whatever is the best possible availability. But main thing is if like there is no hydration, even there can be PCR, but there is not always that vitreous will prolapse. It is when we go ahead with the surgery and then there's a vitreous prolapse more. So early detection is also important. And in SICS, it is very controlled surgery.
Okay, thank you, madam.
Thank you, sir.